As I was thinking about kind of introducing this first session, I thought back to last year, and I think, Greg, I think you were doing this session last year, if I remember correctly, and I was sitting in the audience as a member of the class of 15 wondering, we have so much going on in our healthcare industry, how the heck are we possibly going to do this? And it's daunting, it's scary actually. Fast forward to this year, I don't think it's that much better. There's still a lot going on, but the truth is that's going to happen to us probably, for quite a while in our industry. But to make it less scary, kind of what we can do is what we're doing today. We're all getting together. We're going to hear some case studies. We're going to learn from each other, and we're hopefully going to walk away from here with a new toolkit and a new way to maybe kind of go after some of these things and managing change and making change stick as we go through our processes. So real quick, I'm just going to go over our agenda for the day. We're going to talk about objectives. I'll give a quick overview of the case studies, and then these three folks here will give us some case studies that they've done in their own organizations. And then we're going to have some table discussion. So this is going to be interactive. We're going to let you guys discuss at your tables, and we'll kind of frame that conversation. Barb will discuss that with you about change you've had in your organizations, what's worked for you, what hasn't, and kind of some reactions to the three case studies you're going to hear. And then we're going to bring it back together and have a group discussion. And hopefully we'll have some closing remarks, and you guys are going to walk away with some great ideas for making change stick in your own organizations. So real quick, objectives, analyze these case studies, what's working, what's not, what have they done different that's been maybe led to some success for them. Reflect on your own ideas and changes and things that have worked for you. Identify common barriers and kind of what helps you get past those common barriers. And then, like I was talking about before, gain some new tools to walk away with and new things you can do learning from all your colleagues. So I won't spend too much time to take away anything from these guys that are going to present, but real quick, Hope's going to present on the New York State Health Innovation Plan. Monica's going to talk about Talking is Teaching, which is, and Monica, if I get this wrong, I apologize, but it's about talking to children and growing their vocabulary. And then Darren's going to talk about the journey to a highly reliable organization. So thank you all, and welcome again, and Hope, it is all yours.
So what I'm going to talk about is our State Health Innovation Plan and State Innovation Model Testing Grant. I'm going first because this is new to us, so I'm the least far along and have the most to learn, which is actually a really cool place to be. MHCDS has been instrumental in every piece of this. So the State Health Innovation Plan, which we developed about 2 years ago, is really the, whoops, what did I hit? Okay. The overarching vision for New York State health delivery and payment reform. Okay, can you use this? Okay. It's a roadmap. It's all payer. It's all New Yorkers. And I think the most important point is number 3. It was really an opportunity to take a step back from the multiple innovative strategies that were going on throughout the state, some state funded, some federally funded, some individual providers and practitioners, and create a better integrated and sustainable plan for the long run, because many of them were time limited, they're grant funded. Things like the primary care initiative, there's Medicaid initiatives, there's all kinds of time limited grant programs to test new strategies. So this was an opportunity to take a step back, learn from those strategies, and create a sustainable vision for the future. So these are the key points that we highlighted. We actually had a slide that had pillars and enablers and all kinds of things, but it's really these 6 points: access to care for all New Yorkers without disparity, integrated care delivery premised on an advanced primary care model, which is, it's really the next evolution of patient-centered medical home, transparency, providing payers, consumers, providers, everybody, the most information possible with which to make really informed decisions. Workforce, if we're talking about an advanced primary care model, we have to evolve our workforce, which is really challenging. Payment models, how do we get the payers to the table to pay for advanced primary care? How do we pay for things like care management and case coordination going forward? And health information technology, which is integrated electronic health records, an all-payer database, all of the kind of the platform that we need to actually create this integrated care delivery system. These were our goals and objectives. I'm not going to go into them because I want to get through this and get to some of the challenges and the opportunities, but these are what we stated in our plan and in our grant application, which I'll get to in a second. But basically, they're pretty standard, I guess. 80% of the state's population is going to get care in this new integrated care delivery system. 80% of the care will be under value-based payment strategies, and all consumers will be able to have the information at hand to make better informed choices. Why? These are the kind of the compelling reasons that I learned. We need to have compelling reasons. You could take any one of these and kind of burst it out into much, much more detail. But really, at the end of the day, New York spends a lot of money on health care, and our outcomes are mixed at best. Some are good, some are bad. We're making some progress in things. Avoidable readmissions, we've moved from like 49 to 26 or something like that. So we're making progress, we're getting there, but our health care costs are very high. I think we're number 6 in the nation. And costs for employee health insurance is increasing tremendously in New York State. So that's actually, it's not only the healthcare system, it's an economic driver. So there are many, many reasons why we felt this was key, and we needed to communicate all of these. So now we get to the grant. And this is part of a communication strategy I might want to improve upon, but we took that huge innovation plan and we applied to the federal government for a state innovation model test grant, which we were just awarded. It began February 1, and most of the money is going to go to create this advanced primary care model. And what more specifically is to take 2/3 of the money, we were awarded $100 million, and put it back out in the community as practice transformation grants. The first question, of course, is transforming to what? So that is what we're doing right now, is figuring out with payers and providers in the room, where are we going, what do we want to do, what do we want to achieve, who's willing to pay for what is kind of the key question at the end of the day. So these are the things we ask the money for, but it's really centered on this better integrated care delivery system and a better advanced primary care model. But here's the key for today. What are the barriers to change? And I think I was set up quite well for this. Change fatigue. Medicaid in New York State is changing the way they're going to reimburse people. They're also moving to value-based payment. Medicare just made an announcement that they're moving to value-based payment. We don't really know what that means. Many commercial insurers are changing the way they pay independently, but how do we aggregate that? So if you're a single provider and you have many different people, how do you align those resources? Uncertainty. People don't really know. There's not a lot of hard evidence about what this means down the road. Conflicting needs, priorities, and constituencies. What does it mean to payers, providers, consumers? And from the providers, and I know there's many providers in the room, what does it mean to the primary care physician versus what does it mean to the hospital administrator? Very different things and very different ways to approach it. So this is my list of the barriers to change that we encounter every single day, and that MHCDS is helping me to figure out how to address. The evolving HIT systems, we were just talking earlier about when people inappropriately take information out of there, that's a real concern. Workforce is a huge concern. I call it the third rail in New York. Who does what? Who's licensed to do what? Who wants to give up any responsibility? Who doesn't? Huge, huge question. And thousands of measures. One thing we heard consistently from everybody we talked to is there are too many measures, they're not aligned, we need to do something about it. So that's my list. And I think change fatigue is really the top amongst it. There's too much happening from too many different sectors, and what are we going to do to bring this together to make sense? This is our little depiction of all of the many things that are happening in New York State, and it's really confusing to people. There's just almost too much happening at once. Our Medicaid system has a huge DSRIP initiative happening, which is changing how people are aligned, how they're paid for, how they provide. It's confusing. So I think this is a real barrier and something that we need to address. So how has MHCDS helped? relentless communications that are clear and consistent and urgent and easily understood. I mean, I heard that and it resonated, and I took it back and I used it. I think that there are absolutely places that we have failed and that we need to really improve that. So, but that's one of the key things, is who you're talking to, what are you saying, are you consistent, and do people understand where you're going and why? And I think that's a really key question, and it's not always well answered. Leadership, same thing. If the state has this grant, what's the role of the state as a leader in convening people, bringing people together, executing a strategy, creating a strategy? I think we made some very, very clear mistakes along the way. Consistent communications were not always made to different providers. We were not always compelling. We didn't always understand the downstream impacts of what we were doing, or we didn't think about it ahead of time and try and address it ahead of time, and that created a lot of resistance. So all of the things that I'm learning in leadership are helping along the way, and as we're really pushing off, I think that I'm going to go back to make sure that we do this. Whoops. This was not the last one. Uh-oh. Lost a slide. That's okay. I have it here. There was one more slide that I wanted to make sure that I got to in terms of, okay, other things that I learned in MHCDS. Sorry that I don't know where the slide went to. But back to communications, absolutely important. Health economics and policy and finance, really understanding the downstream impacts of what we were talking about when we go out there and say we're doing value-based payments. What does that mean? And what does it mean to whom, when, where? And I think the finance class really clearly helped me to understand that better from particularly the hospital perspective, where some of the greatest resistance is in New York State. And then the last thing I wanted to point out that was really important is negotiation. That was a critically important class, truly, to really clearly think ahead about the interests, the alternatives, the options, legitimacy, commitments, relationships, how you communicate to each and every one of those individuals, and thinking 3 steps ahead every second, every day. And that's something that I haven't had to do, honestly, until undertaking this initiative. So that was another really key piece of it. So I would say there's not a class that I have taken that has not helped me in each and every day in what I do. And the challenges continue to be huge. The resistance to change is significant. And you know, in the words of one of my colleagues, we want to create a system and make payers, providers, and consumers an offer that they can't refuse. But we're not there yet. So that's the challenge ahead. So I look forward to learning from everybody.
Hi, everybody. I'm Monica from the first class. I'm just going to set this up. It's a little bit of a different presentation, and I just hope you all will be interested. Just to give you a little context, so I work for the George Kaiser Family Foundation, and I'm in the same job I was when I started the MHCDS program. George Kaiser Family Foundation is a nonprofit charitable organization focused pretty much on Tulsa, and we make investments in early childhood learning, community health, and civic enhancement, education all over. We're pretty much a large foundation. So if you can't come to Tulsa without seeing our footprint. It's everywhere in many different ways. We're currently building the largest privately funded park, invested $350 million to build something on the scales of like a Central Park in Tulsa on the river. So there's a lot going on that we're involved in. Our foundation is focused mainly on anti-poverty. And to give you a little bit of context of Tulsa on how big we are, we're about a 600,000 people city. We have all the problems you can imagine, 25% uninsured, highest in female incarceration. Jeff, help me out. Jeff's my city mate here. All kinds of things that just, we're a melting pot. We have a lot of immigrants, currently have a lot of Burmese immigrants, so things you wouldn't necessarily expect in Oklahoma, just a lot of poverty, and what we're trying to do is get people out of poverty. This initiative has really personally been a bit of a change for me because I've been managing the community health portfolio, which involved medical education and it involved access to health care for the uninsured. So now we're switching into this initiative, which is, it's called Talkies Teaching. And you all probably, especially most of you physicians in the room, are familiar with the word gap. And the word gap is that a child born in a low-income family or a family that doesn't necessarily focus on them will hear a lot less words by the time they go to school. So they enter school just not as ready as a child born in a normal household, in households like that we were born in. And there's more and more research that says that this word gap and the literacy gap is what's making a difference to high school graduation rates and really setting people behind. So this campaign sort of focuses on the word gap, but on a lot more. And the campaign it's called Talkies Teaching, and it's actually a collaboration of many different organizations. And the reason I thought you guys would be interested in what's going on in Tulsa, it's going on nationally. Too Small to Fail is an organization that Hillary Clinton has started. It's part of the Clinton Foundation. And if she runs for president, you'll hear a lot more about it. But she's focused on this whole initiative of it's very important to parent early and to teach parenting skills early. Most kids are born without having that help these days if they're born in single households or they're born to a parent who's in jail, which is happening everywhere, and they're just not getting the attention they get. 90% of most brain development happens before age 5, and those of you that are pediatricians and others in the room know that. So, you know, the premise is, and we don't know for sure if it's right, but there's a lot of research that says it, is the premise is that focusing on kids before age 5 will make a difference to changing the trajectory of poverty in this country. The U.S. has had stagnant states of poverty for 30 years. We haven't reduced the poverty rate, which is kind of a shame for the richest country in the world. So this is a new initiative aimed at saying, you know, if we focus on our youngest and we take it beyond the walls and take it to everybody, take it to doting grandparents and take it to everybody that focuses on children and teach them that it's very important to talk, read, and sing to your children, that's going to make a difference, and use every moment as a teachable moment. That's really the premise of the campaign. So what we did was, the main thing that the campaign involves is a medical outreach. And this is where the change effort comes. We realized that we did some focus groups, and these were done in several cities. It was done by the Clinton Initiative as well. And the focus group said that the trusted advisors for families and parents are their doctor is the #1 trusted advisor. When they're in the hospital, that's the #1 trusted advisor. Their pastors and people at their church are trusted advisors. Neighbors, grandparents are trusted advisors. So we realized that that's who we need to focus on. Well, as you all know, doctors are super busy. How do we go into their offices and say, hey, do one more thing yet? Or in your well child check, make sure you're talking about reading and doing those things. So we knew this was going to be the biggest challenge and the barrier to overcome, is if we can get the medical community to buy into this initiative. The first thing we did was we had a huge meeting where we called every OB-GYN in Tulsa, every pediatrician, every family med doctor, and we had a few well-known trusted people speak to them. So the former president of the American Academy of Pediatrics was there. Mr. Kaiser himself, who's alive, you know, billionaire in the community that people know, but believes in this initiative, spoke. And so we got buy-in that way. We got people, the Commissioner of Health and people like that to talk about it, and really have had a lot of enthusiasm from the medical community. So it's going well. It's been going for about 4 months now. I don't know how it will go and whether it'll continue. So the first thing we're going to do is we've hired, every OB-GYN doctor is going to give a bath kit to the new moms, 1,000 new moms hopefully we're hoping to reach. And then the big thing is we've hired 4 nurses through a social service organization that will be at every hospital and go to every mom as soon as they're born, and you'll see some pictures of the kits. They'll be getting a kit, and it's talking about talk to your baby, read to your baby, sing to your baby, use it as a teachable moment. So that's the big thing, is the medical outreach. And then how many of you are familiar with Reach Out and Read? started in Boston by Barry Zuckerman, and you all in a clinic that uses Reach Out and Read. So we've basically taken Reach Out and Read to every clinic, which is, it's a program where books are given at every well child check till the baby's 4. So that's nice. Besides the medical outreach, we're also doing a broad public outreach. So just tons of advertising everywhere, newspaper ads, Spanish and English ads on the radio. We're going to have at local gas stations, we're going to have information and posters everywhere, tons of social media push. So just trying to see that everybody hears about it, and hopefully that will create something. And lots of billboards. Jeff, you seen any of the billboards in Tulsa? Yeah. All right, and then we also have a faith-based outreach. We have 9 churches and basically primarily the African American part of town who are doing literacy nights, and we have 40 pastors that have bought into this. They're making it part of their sermon. They're telling everyone that it's important to engage with our young. And then this is what the tools look like, and these were developed by Sesame Street, and it's actually right now 3 cities, New York and Oakland and Tulsa, that are piloting this, where this is the bag with like there's a onesie in there and a little blanket and all those books and DVDs that will be given to every new mom. So it's just something that they can take home that's a reminder and keep it going. And then we've developed these little prescription pads for reading, like the old way. You guys all do e-scripts now, but you know, the doctors can still write a little prescription for reading. And there's these posters that are everywhere that we're putting them up in clinics, and trying to just like little pithy phrases that your baby learns from birth. And essentially, you know, this is the message, which is every activity is a teaching moment. That's really the campaign. You'll probably see some of it. I have a feeling it's going to go national. More and more cities are wanting to get on board. The Robert Wood Johnson Foundation came out and visited us recently, and we're considering having sort of a big national meeting this fall in Tulsa to highlight this work for cities and communities that would be wanting to sign on to do this and do it more in their communities. So.
Darren Vi, class of 14. I am currently the commanding officer at Naval Medical Center, Portsmouth, and I'm going to talk to you about a journey to a high reliability organization. I'm going to try to keep it short and concise. I'm going to let you know, though, I have to point out that the bottom, the views expressed of these are the presenter and do not necessarily reflect the official policy or position of the Department of the Navy, Department of Defense, of the United States government. As a matter of fact, my slides were censored, which is, the irony is not lost on me, and Patrick already picked this up. Part of a high reliability organization is actually transparency. So it cracked me up that my slides were censored, but I'll try to fill in the blanks. They were worried that people within the Beltway, within the Pentagon, and within the DC area might see things that they might take out of context and interpret them different ways than we would intend. But many of you are probably already aware of high reliability organizations. It's not a new concept. It's been around for quite a while, originally described back in 1987 academically, and I will get into the initial group that described it. But about 15 years or so ago, with Joint Commission, with AHRQ, a lot of people tried to bring high reliability into healthcare. And again, I would say it's interesting, Katie, you gave me the make it stick piece, because it is in its infancy, and we are in its infancy within DoD. But what is unique about us is that based on, which many of you probably read the report of this, the SecDef review of the military health system, he actually mandated in 2014 that DoD, the Defense Health System, will move towards a high reliability organization and use those concepts in developing our healthcare system. So real quick, for those who aren't familiar with it, what is it? It's an organization that's preoccupied with failure, doesn't oversimplify observations or experiences, sensitive to operations. I use the term Deckplate. It realizes that things actually happen at the Deckplate level. Is committed to resilience, which is unique, and I'll get into that as being one of our barriers, and defers to expertise. Why is it important? This one wasn't hard, particularly for this group, and the good news is that in Navy medicine, one of our strategic imperatives is actually value. They define it slightly differently. They added capacity to the numerator. But you know, ensuring that we provide the best outcome at the lowest cost. And if you're a high reliability organization where you're ensuring that there is zero patient harm, you're going to improve the value of healthcare, you're going to decrease the cost of healthcare, and overall that value is going to be improved. What are some of the barriers? This is the list that they made me put into a generic list, but I'm going to give you the 4 things that I think have been the most important for us at Naval Medical Center Portsmouth. Number 1, and I'm looking at Chris back there, because Chris, you guys know, is a former submarine officer in the United States Navy. And it's interesting because I was actually a submarine medical officer in the United States Navy, and the submarine community is one that's been identified as a high reliability organization. But what's interesting is the submarine Navy also has a zero defect mentality. And I would argue that is not a high reliability organization. And I would tell you the biggest challenge we're facing in healthcare, and the biggest challenge that I see at Naval Medical Center Portsmouth is that a fear of reprisal is our greatest obstacle to becoming a high reliability organization. I think the other things are pretty generic. They are standard there. I have very young staff. My average nurse in my ICU is in her first tour. My staff turns over every 3 years. Communication is the #1 cause of a root cause event at Naval Medical Center Portsmouth. They made me take that out too because they said I don't have the statistics to prove it. If they listen to the video, I can show them the statistics that prove it. But how do I communicate a strategic plan, and how do I execute at the deck plate level when communication's the #1 problem that I have whenever I have errors, period? And then I think the other thing, and you've heard it earlier, we have metric madness. We have it in DOD, and that was actually one of my comments too. We call it, Metric Madness Day, where we look at all the metrics that everyone's measuring us on. But those are the greatest barriers I've found, along with the standard barriers that we have. What have we done as leaders? You're going to start picking up some MHCDS stuff probably now. But when I got there, I was actually the deputy commander at the hospital 4 years ago. Went to PAC Fleet out in Hawaii, had a rough tour, had to live in Hawaii. Everyone had to look at me in the little box with the beautiful purple sky behind me. But I'm back at Naval Medical Center Portsmouth, and the first thing I did was engage my leadership. Where are we going, what are we doing? Making sure that they were aligned with the understanding of what a high reliability organization was, and actually made them go back and read a 1987 article that was written about, the original article written on high reliability organizations was written by a naval aviator on United States Navy aircraft carriers. And I point that out because the other barrier I'm going to tell you about, remember I told you I had 40% staff turnover and I have about a very young population. United States Navy aircraft carrier, flight operations, it was written for the exact same reason. And one of the questions was, how do they do it? #1, standards, policies, and procedures, but #2 is watching for that deviation, watching for deviations in processes and picking them up. The unique thing is, and Scott knows this, everyone else, or Chris knows this, everyone else may not, but that's Chief Petty Officers in the Navy. That's what they do. So with this, some of the things that we're looking at doing, I'll get it in another slide, but I'm actually looking at hiring people, probably starting off with 5 to 10. Johns Hopkins actually has a program where I'm bringing people in who do nothing but work across product lines to look for deviations in processes and procedures, and being so ingrained and so familiar with the organization and the people in the organization that fear of reprisal for pointing out deviation goes away. It's not going to be perfect, but that's some of the things that we're doing. We measured the current culture. I'll get into that in just a little bit. Again, I have been preaching. When I went through the course here, and some of the professors know I continually asked it, and you'll see this in my short talk here, but I've done a lot of work with strategy, and I've done a lot of work with execution. But I've not seen a lot of work done, even in the academic world, ensuring strategic and operational alignment. I think that is the hardest thing that any group and individual can do. As a matter of fact, while I was gone, for those of you familiar with 4DX, that was what was brought in as our execution tool at Portsmouth, and I love it. It's great. It does a perfect job. You don't have to use 4DX. You can use whatever you want. But I laugh because I'm like, really? Sean Covey wrote a book that said his dad was wrong? It's not about strategy. It's about execution. And what I've learned through my time in the Navy and in various leadership positions, it's that alignment that is the toughest piece. And I think if you look at it, strategy, structure, processes, rewards, and people, that's what brings that alignment together for an organization as you're trying to make any change and ensure that you're cohesive in that piece. This I put up again just because we stole this from Chasen and Loeb, which is an article that you can find on the Joint Commission website, but these are some of the elements that are definitions of a high reliability organization. To determine where you are in the process, you can see down at the bottom left there's a key which says beginning 1, developing 2, advancing 3, approaching 4. We actually sent this out to our staff. I've got 7,000 staff, only about 100 or so is that we sent it out to, but I sent it out to my leadership, sent it out to my staff. We actually had very good correlation across the two in the responses to the answers, which I was very happy with. And we came back with about a 2.8, if I gave you the average number. And again, I thought that was pretty reasonable in the sense that we are a little above developing, but we are not quite advancing. And the thing I would point out is there is no 5. There is no you made it in a high reliability organization. The highest it goes is a 4, which is you are approaching. Leadership, culture of safety, and robust process improvement are the 3 things that are his main elements of a high reliability organization. And like I said, we've measured those and we utilize those. So what are the next steps? How do we make it stick? Number 1, message alignment. Again, making sure we are doing these things. Making sure it comes, I'm going to jump down to the bottom. Reward, reward, reward. Again, in the military, things that I have, fitness reports, performance appraisals, recognitions of sailors of the year, officers of the quarter. Some of you know because I've given them out before, commander's coins. When I hear of a good catch, I walk up to the warden and I give a coin out. Not only do I give a coin out to the individual that had that catch, one a couple weeks ago was a nurse who the pharmacy had sent up 100 milliequivalents per mil instead of 10 milliequivalents per mil of potassium chloride. They got their decimal off. It had been compounded wrong. I not only gave it to the coin to the nurse that caught it, but I actually gave a coin to the administrative tech who took the time to put it into the system. Because that's one of our biggest problems across the organization. If we don't capture those errors, we never identify where the errors are going on throughout. We're no utopia. Our patient safety reporting is terrible, just like the rest of you. But that's some of the ways we're trying to break that down. Robust process improvement, I already told you that we use 4DX as our execution tool. We use Lean Six Sigma as our process improvement tool. What I've actually done is I have a director of strategic and operational alignment. And what he owns is he owns the teaching, the training, and the oversight of the 4DX, and he owns all of my green belts and my black belts for Lean Six Sigma. So it's kind of a one-shop. I won't call it an innovation cell because I think we'd barely be box 1 in innovation. We're sure not box 3, but kind of a one-stop shop where that's their focus. They're removed from doing other things. Making sure that there's leadership support, just continually monitoring it and coming back. And then one of the things I also do is we're actually planning. So again, to tie all this back together, and it's hard to give you a real picture of where we are and where we're going, I would say we're at the infancy stage. What we've done is I met with leadership. We brought back together the strategic imperatives of where we have to go, the lines of operation of how we're doing it. I've met with all of the command, which is 7,000 people, both when I initially got there and now I'm meeting with them all again in different breakdowns. The first time was kind of by, we call it GS workers, civilians, you're enlisted, you're officers. Now I'm meeting with them by director. We're going over the strategic plan, which has been aligned, pointing out where they work and function in the organization for them to help move it forward. But the next phase is, and I'm bringing back a 4DX team, which is going to teach each directorate's leader on 4DX, which they've been taught before, but to bring it back to execute at that Deckplate level. And then I'm going to have a stand down where we bring in some nationally renowned speakers that talk again about what is a high reliability organization, why is a high reliability organization important, but then actually pull that aside and have deliverables where they have to give me some of the initial identifiers of what the measurements, performance, and measurements of effect would be in developing a high reliable organization. And again, I did a little bit differently, but one of the questions was, you know, how did this course affect and change what you're doing? And I don't think you could probably look through any one of the courses that we did and not say that it has not had an effect. And I find myself every day teaching my board of leaders on various different topics that we've learned here at the MHCDS. I think the biggest part, which you all know as well as I do, is the challenge is taking each one of those components and actually being able to put it coherently together to implement that change management and then to sustain it. So, and I have a little saying, which is what I've seen in a lot of organizations that I've been at. Some of you've seen before, but strategy without execution is a dream, and execution without strategy is Brownian motion. And you'll laugh at me a little bit because I wondered, is the right answer Brownian motion? Because one of my friends said it's busy work. And I don't know about your organizations, but I went back, I looked up the definition of Brownian motion, and Brownian motion is the random action of molecules when acted upon by random outside forces. And I can guarantee you that my organization was all over the place as a result of random outside forces, and we still are. But I think if we get that strategic alignment again and we get everyone taught on the direction we're going, knowledge is power, and it empowers them to move forward and understand how they can execute. And that is all I have.